Thank you very much, Holly. So why study types of clinical birth settings? The impetus for the review was rooted in prevailing concerns about the technological focus on birth that is common in many hospitals and has prompted the design of different types of birth units. And these are around the world. I'm not talking about just in the US. Against that background, there have been some amazing studies, and I think Dr. Sternberg may refer to some of those later, of medical and surgical hospital wards, which demonstrate that the actual built environment, the physical environment, can influence length of stay, the development of complications, and patient satisfaction with care. So the setting for birth is an important area for study. In this Cochrane review, we found or searched for a wide variety of hospital settings. There are three types that came to the fore. First are typically called home-like room or rooms, but in fact they're bedroom-like. We would not call them home-like, but they are bedroom-like. They can be within the hospital labor ward or a separate unit within the hospital. Then there's the ambient room, and I have to take some, I guess, responsibility for coining this term, but it came from my understanding of the literature about what are health-promoting aspects of the hospital environment. And they are ones that include scenes of nature, either real ones, if you're lucky to have a window that looks out on something other than another building, or artificially imposed ones in the room that offer opportunities for music, for freedom to move, in which the labor bed is the typical hospital labor bed is not part of the room, and instead there's a large mat with pillows off in one corner. So the ambient room is meant to promote feelings of control, freedom of movement, and calmness. The third type of room is the Snoezelen room, which has actually been used for people with neurologic brain disorders. It's an interesting contrast to women in labor, but they include multiple sensory stimuli, including fiber optic lights, sounds, and aromatherapy. And we found a descriptive qualitative study in Australia of women's experiences in a room like this. Now, in all three of these types of alternative hospital settings, they may have both the same staff caring for women that care for them in the typical hospital labor ward, or it may be separate staff. And I'd ask you to keep that in mind as we talk about the Cochrane review itself. So our objectives were, first, the primary objective was to evaluate the effects of care in an alternative birth setting compared to care in a conventional labor room. And secondarily, to determine if the effects of the care vary based on certain characteristics. First of all, whether staffed by the same or separate staff. Secondly, whether continuity of caregiver was also part of the alternative setting. Thirdly, their location, physically within the hospital labor and delivery ward, as a separate unit within the hospital, or a freestanding unit. And finally, their type, this bedroom-like or ambient or Snoezelen. As with nearly all Cochrane reviews, we were searching only for randomized controlled trials, and I don't have to tell you why we use that as the basis for the review. The intervention was care in an alternative institutional birth setting. In other words, this review did not include home birth, and the participants were healthy childbearing women. I should point out that when we talk about alternative institutional birth settings, they had many different attributes, these settings, but the design was, in each one, was based on the philosophy that childbirth is a fundamentally normal process. And that philosophy then dictated the policies and procedures in the setting. Our methods, all analyses were by intention to treat. In other words, women were analyzed in the group to which they started out having care in one setting or the other. We had pre-specified primary and secondary outcome measures. The search strategy included the world's literature, regardless of language or whether it was published or unpublished literature. There were independent assessments of the eligibility of the trials based upon their methods and risk of bias, the assessments of risk of bias in the trials. We conducted sensitivity analyses to, for example, remove the weaker trials from the review to see if that would change the conclusions of it. And we had pre-specified subgroup analyses. In other words, if we were hoping to be able to look at whether or not the effects of the care in the alternative setting would alter based upon certain characteristics of the trials. So we ended up with 10 randomized controlled trials involving 11,795 women. There was one trial provided us with no relevant data, in other words, no data for our primary or secondary outcomes. The trials were conducted, 2 of them in Canada, 1 in Ireland, 1 in Australia, 1 in Sweden, 3 in various parts of the UK, and 1 in Norway. We found 1 pilot RCT of an ambient room. It wasn't hard to find it since I had been the PI of that small pilot trial. I'm looking for people to take that forward, by the way. There are no randomized controlled trials of the Snozelen room, no randomized controlled trials of freestanding birth centers, and 8 randomized controlled trials of these bedroom-like settings within hospitals. Of those 8, they varied in some of their characteristics. So 5 of them provided some antenatal care as well as intrapartum care, so there were elements of continuity here. 3 of them had separate staff in the alternative setting compared to the labor and delivery ward. And of those 3, all 3 had continuity of caregiver as their modus operandi. They shared a common philosophy that labor and birth was a fundamentally normal experience. They all restricted the use of technology during labor and birth. In general, physicians were not involved in the labor and birth in the alternative settings unless they were needed. And they were characterized by high transfer rates either before or during labor. And you'll see the wide range here from 29% of women who were randomized to a setting up to 67% in one study who ended up not giving birth in that setting. Okay, so what did we find? Women who were randomized to the alternative birth settings were more likely to labor and give birth without any analgesia or anesthesia of any kind. That comes from 6 trials of almost 9,000 women. They were more likely to have a spontaneous vaginal birth. That's 8 trials of over 11,000 women. And in 2 trials, unfortunately only 2 that actually asked women how they felt about their experiences and got a large enough sample of them to respond that we could say anything in the review. But in those, they were more likely to say that they preferred the same setting the next time if they'd been allocated to an alternative birth setting. Women randomized to alternative birth settings were less likely to have any intrapartum oxytocin, and that's from 8 trials of about 11,000 women. Less likely to have epidural analgesia, another 8 trials of almost 11,000 women. Less likely to have a cesarean birth from 9 trials of over 11,000 women. Less likely to have an assisted vaginal birth, 8 trials, 11,000 women. Be really nice if every trial studied all the same things, but they don't. And less likely to have an episiotomy, again from 8 trials and about 11,000 women. We found no significant differences in postpartum hemorrhage from 6 trials and 10,000 women, serious maternal morbidity or mortality, just 4 trials reported on that, serious perinatal morbidity or mortality from 5 trials, no significant differences in the number of babies with a 5-minute APGAR score less than 7 or with admission to a neonatal intensive care unit or in perinatal death. Now, our subgroup analyses, only one subgroup analysis was possible because of this problem of not being able to separate and the confoundingness of continuity of caregiver and same versus separate staff and so on, and the lack of trials of freestanding centers. However, we were able to conduct a subgroup analysis of, did it make a difference whether it was the same staff caring for the women as worked in the traditional labor and delivery unit, or if the staff were different. And there had been, certainly prior to this, a reason for looking at that was the feeling was that it was a lot to ask of midwives and nurses to work in a, say, a tertiary care setting where there's risk and there's detection of problems and so on, to kind of shift gears the next day and work in a birth center where the philosophy was quite different and women are low risk and so on. However, our results did not suggest that there was an effect on spontaneous vaginal birth or on serious maternal or perinatal morbidity or mortality. Our results are consistent with other studies of the independent effects of hospital architecture on health outcomes. However, the benefits of an alternative setting may be overpowered by institutional norms and policies. If you had a look at some of those relative risks, they were quite modest. You know, they're significant, but they are modest. And I think it's important to keep in mind that when you are part of an institution, you are subject to the norms, stated and unstated, the policies stated and unstated of that institution. We talked about implications for practice and said that pregnant women should be informed that alternative hospital birth settings are associated with lower rates of medical interventions during labor and birth and higher levels of satisfaction without increasing risk to themselves or their babies. Decision makers who wish to decrease rates of medical interventions for women experiencing normal pregnancies should consider developing birthing units with policies and practices to support normal labor and birth. But they have little to go on when making decisions about staffing models, organization of care, autonomy of the setting, or its architectural features. So there's a great research agenda here for anybody that would like to take it forward. We hope in the future that studies measure and report serious perinatal morbidity as well as mortality, that clear protocols for consultation and transfer of care are present. We've already heard about the importance of transfer, that they address the potential confounding effects of continuity of caregiver when you're trying to actually determine whether or not setting makes a difference. We would encourage evidence-based approaches to get high response rates to postal questionnaires from women, and of course to include cost-effectiveness analyses. We'd love to see some RCTs of freestanding birth centers and RCTs of alternative birth settings which are specifically designed to promote freedom of movement, feelings of calmness, and a sense of control, as well as studies to determine the optimal organizational models of birth center care. We'd like to see qualitative studies of the impact of transfer on women, care providers, and decision-making processes regarding the need for intervention, and qualitative studies of the impact of competing philosophical, political, and administrative pressures on the operation of alternative settings. I'd like to argue for a shift in focus. Cesarean rates for otherwise healthy childbearing women may have as we saw this morning, actually stabilize a little bit. They're still shockingly high, despite widespread efforts to encourage providers to adopt evidence-based practices. My own view is a shift in focus from efforts to change providers and women's behavior to altering the clinical environment for labor and birth is promising, timely, and worthy of rigorous evaluation. And I'd like to close with 2 slides that come from a journal called Antipode, a paper by Fannin called Domesticating Birth. This is a bedroom-like setting. It's a labor and delivery setting, but I'm sure you're aware that many of these settings are now called family birth centers or sort of things like that. They're labor and delivery units. Let's call a spade a spade. This is the room that the woman saw on her tour of the hospital. And this is what it looked like after she was in. Now, tell me that that's an alternative setting that promotes feelings of calmness. I particularly, as a nurse, look at the stool there and wonder how anyone can provide labor support when that's all you've got to sit on to be with a woman in labor. I'll stop there. Thank you.
Thank you, Ellen. So our next speaker is Professor Jane Sandel. I just want you to note that in her biography in your little booklet, all of her degrees except one got left off. She has a string, including a PhD in sociology. She comes to us from King's College London, where she is a professor of social sciences and women's health. She has led a research program in the National Institute of Health Research for King's Patient Safety and Service Quality Research Center, including the exploration of care escalation in medical and maternity settings and the implementation of rapid response systems in perinatal care. Professor Sandel will present today the results of the largest cohort study to date on birth settings in England. Please welcome Professor Sandel. Thank you.